right, welcome everyone. We'll get started. All right, so this is a talk I've really been looking forward to. And for those of you who don't know, this is the Foundation for Community Psychoanalysis. And this speaker series is called Psychosis in the City. Here we bring scholars, community mental health workers, and others into a kind of conversation that brings together the work of community mental health, understanding the politics, history, political economy, and sociology of these issues, together with the subjectivities of the people whose lives are often squeezed into very sort of bureaucratically and politically circumscribed circumstances. And so it's my pleasure to introduce for you today our speaker, Neil Gong, who is an assistant professor of sociology at UC San Diego. He's the author of Sons, Daughters, and Sidewalk Psychotics, published by University of Chicago Press in 2024, and co-editor of Beyond the Case, The Logics and Practices of Comparative Ethnography, published in 2020. Neil's public writings have appeared in such venues as the Washington Post, The Atlantic, and the Los Angeles Times, and he'll be speaking today in large part about that work, Sons, Daughters, and Sidewalk Psychotics, but I think has a kind of particular take on that for our audience today, which includes a fair number of people who are working in community mental health. So, thanks, Neil.
Thanks, Chris, and thanks to Sienna for putting this together, and thanks to all of you for coming on such a nice day outside. So happy that people actually made it. This is also really exciting for me because at one point in time I thought I might become a clinician, in an alternate life. My first job after college was on a community mental health treatment team in East Harlem. So I could all sort of thinking about these alternate paths one could have taken in life. So this is exciting for me too, to speak to a kind of more psychodynamically oriented audience. I've given talks for sociologists, like psychiatric grand rounds. Yesterday, actually, I was at Princeton Global Health, so very different kinds of audiences. I'm always interested in what kind of questions and ideas people have and how they respond to the work. So this is a section of this book, which was mentioning, called Sons, Daughters, and Sidewalk Psychotics, which is a comparative ethnography of intensive outpatient psychiatric services in two very different parts of Los Angeles, two very different sectors: public safety net care in downtown LA, and then elite private treatment in West LA and Malibu. And the basic conceit of the book is that since psychiatric deinstitutionalization, since the US closed the majority of its state mental hospitals, we've been talking about this thing called community care, as if it's in the singular, when in fact, I find that we have very different community care for different communities. And today I'll be talking about how this manifests in unequal experiences of illness, unequal definitions and experiences of recovery, and even unequal ways of thinking about and practicing freedom and client choice. And today I'm going to talk about people who get processed these very different ways in these different clinics, and how it takes place not only through material inequality, but also through what I'm calling social prognosis. And so what do I mean by this? If we think about a psychiatric prognosis as describing the predicted duration, course, and function around illness, the social prognosis is about the types of lives, identities, kind of imagined futures people with those illnesses can have. And the core argument for today is that the social prognosis is located less in the patient than in the clinical context in which they're embedded. And so here's going to be the argument in a nutshell. When mental illness is conceived of as a problem of urban policy and public space, the kind of imagined recovery they have for people, the social prognosis of what they're aiming for, is making that person not in jail, not homeless, and not triggering too many 911 calls. And this is going to lead to a set of practices that make sense in this world. Housing first, so trying to get people into stable housing without treatment compliance or sobriety preconditions, a variety of harm reduction interventions. And this is going to lead to particular ideas around client choice, kind of one of the ironies I'll highlight is that poor marginalized patients end up with, at least in some sense, a great deal of autonomy. On the other hand, when mental illness is conceived of as part of a crisis in privileged family systems, it leads to a very different vision of recovery, a very different social prognosis here of helping people achieve class-respectable identities. There are a series of practices and treatment interventions that make sense in that world. All kinds of therapies for normalizing behavior and kind of transforming people. And the irony here is that you have a great deal of behavioral control in elite settings that families are spending quite a bit of money on. So I'm going to be walking us through 3 research literatures that I'm building on and bringing together, but I'm going to be taking a kind of sort of sidestep to ask slightly different questions than they do, but I'll work up to that. So first is thinking about class inequality and serious mental illness. So you may have seen something like this, this gradient here, showing that, as generally speaking, as you go up in socioeconomic status, you have less serious mental illness, diagnosis at least. And this is like a classic psychiatric epidemiological finding. People debate precisely what it means. Some people say, in what they would call a social causation model, that people who are exposed to more stressors are more likely to develop illness and be sicker. Others have what they call a social drift model, that people who become seriously disabled kind of fall through the class structure. Although most researchers at this point would say these are compounding and complementing explanations, not kind of opposed. The next literature I'm engaged with, but again, I'm going to take a slightly different tack on, is literature on self-fulfilling prophecy with psychiatric diagnoses. So in the 1960s and 70s, sociologists and others had what they called labeling theory. The basic idea was that by labeling people as deviant in some fashion, you might end up creating that kind of deviance. The classic example here would be something like calling a youth a delinquent, and then based on the way that changes their self-concept and the way that perhaps the institution of the school processes and treats them, you end up inducing this kind of delinquent identity and behavior. And at its more kind of bold, the labeling theorists made a similar claim around serious mental illness, that labeling somebody with a diagnosis of schizophrenia, for instance, would change both their self-concept, how others react to them, and over time induce a kind of either crazy behavior or mental patient identity. And by the 1980s, most labeling theorists had given up on this kind of full ideological claim. So they weren't claiming that calling people mentally ill was driving people to mental illness so much as the way that labels, highly stigmatized labels like schizophrenia, could lead to stigma, rejection, and these kind of negative self-fulfilling prophecies. And then precisely because of these negative self-fulfilling prophecies, you had patient activists pushing for what they called recovery, which has now become a pretty common idea, but at the time was considered pretty radical. So they wanted clinicians and others to focus on people's capacities instead of deficits. And again, this goes from being pretty radical to then being codified in things like the Bush New Freedom Commission on mental health, the California Mental Health Services Act. These are all in the early 2000s. And so here's just one definition of recovery from some Yale folks who work on this. Recovery identifies and builds upon each individual's assets, strengths, and areas of health and competence to support the person in managing his or her condition while regaining a meaningful, constructive sense of membership in the broader community. So as I mentioned, I'm working with all of these ideas, but I'm trying to take a slightly different tack. So I'm not precisely asking, are people sick because they're poor or poor because they're sick? Not really. I'm taking a slightly different approach to self-fulfilling prophecy. And the interesting thing about recovery here is it's not so much like, are the clinics that I studied using recovery model? In fact, pretty much everyone in community mental health will invoke some version of this idea of recovery. So for me, the focus for the day is going to be, what are the visions of recovery that are available for people of different social classes in these different kinds of clinics? And then how, in turn, do these approaches and visions of recovery shape practices in people's lives? Just say a little bit about the research methods here. So I'll start with the logic of comparison. And people often ask me, why are you focused on the public safety net for the poor and then elite care for the rich? And part of it is because of something I found empirically doing the research, which is that when I was leaving the public safety net and was trying to see what else was out there, I wasn't really finding good middle class models for serious mental illness. I would go to things like a National Alliance for Mental Illness meeting, support group, talk to families, and they'd be in this kind of dilemma. Do we take maybe like our adult child off private insurance, move them to Medicaid in the hopes of accessing community mental health services and maybe some social service support services? Or do we go into debt, take a second mortgage on our home to try to pay for the elite care that was available locally? So this was kind of like a way people felt stuck. Analytically speaking, this kind of stark comparison makes the dynamics and mechanisms at play more visible. And part of the idea here is that by putting these things side by side, things that feel obvious or feel natural in one setting, when contrasted, suddenly become much more problematic or something to be explained or something for us to reconsider. And then just one thing to keep in mind as we go through, I'll be talking about patients kind of heuristically in the sense that like I'll tell their story, but ultimately my goal is focusing on how the clinics or the organizations as units are thinking of and processing people. So just in that sense, the organization is more the unit of analysis than individual people. A little bit about the primary clinics, each of which is embedded in a larger clinical ecology. So each of these is a variation on the assertive community treatment team model. So kind of was considered the gold standard of community psychiatry, interdisciplinary community case management, with the capacity to visit people in their homes or out in the field. And each of these was born of the deinstitutionalization movement. So at the Department of Mental Health, I'm calling DMH, they have their public teams. The actualization clinic is essentially a private version of this, a private ACT team. And they have this kind of similar model, although they've evolved some organizational differences. So at DMH, you have a client to staff ratio of about 16 to 1, which is quite good for public services. At actualization, you have about 8 to 1. At the DMH, you have 3 of the 8 people who are working and can do these kind of field-based visits with a master's degree. At actualization, all the field-based people have masters. A lot of them are pursuing their licenses, and yet trying to get enough hours. I should say that each team is run by a PhD clinical psychologist with a social worker. At the DMH, they have a staff psychiatrist for the team. At actualization, almost everyone is coming in with private psychiatrists. Funding is very different, so a variety of different kinds of state funds for DMH. At actualization, it's primarily private cash pay. As I mentioned, like commercial insurers often won't cover things like this. So you're paying maybe $5,000 to $6,000 a month for home visits. In many cases, the residential programs they collaborate with in the area could run from $30,000 to $50,000 a month. So it's a lot of money. And then in terms of classification requirements, at DMH, you need a diagnosis of serious mental illness, plus some combination of homelessness, jail, and hospital discharge. Whereas at the actualization clinic, there's really no classification requirement. It's really a question of whether your family can pay for it. And then in terms of methods, I was a volunteer with a full service partnership is the California kind of lingo for assertive community treatment, this kind of team case management model. And so I was a volunteer there. I did a lot of street outreach, went on home visits, spent time in groups, and just like hanging out with people. And then I switched to kind of go across the proverbial tracks. I became an intern at the actualization clinic. And then I visited a variety of providers they worked with. So there's residential treatment facilities, kind of elite dual diagnosis sober living homes by the beach. I was able to attend groups, case conferences, but I will say my access was much more limited. They wouldn't generally let me go on like home visits. I think this is a pretty common thing. It's very hard to do this type of field research with elites, but I tried to cobble it together by getting to different kind of parts of the overall, what I would call kind of organizational ecology. Okay, so here are going to be the 4 points of comparison we're going to think through today. So first is what I'm calling the clinical project, kind of like what do they think they're up to? Like what is the organization's point? Then I'll talk about this social prognosis again. How are they imagining their clients' futures? What does recovery mean? Then we're going to talk about mismatch. So what happens when there are people who, where they're at simply isn't really fitting kind of the clinic level idea of what's supposed to be happening. And then what does this all mean, number 4, for client choice and how they think about and practice ideals around client choice. So first, again, clinical project, what do workers think they're doing? What's their organizational purpose? At DMH, it's primarily about managing urban poverty. Whereas at the actualization clinic, it's going to be about managing these kind of crises in elite family systems and trying to help people recover their kind of lost identities. So at the DMH, a big part of what they do is bound up in LA's homelessness crisis. And so here's what Laura, the DMH team leader, once said. We're not so good at the rehabilitative side. It's no one's fault, really. It's just once we've covered the basics with one person, we have to move on to the next person to get them housed. And this is also, you can also see this in the kind of quantitative metrics they're oriented to and that they have to record. So this was from the LA County Outcome Data Report I was reading this when I first started fieldwork, so it was from the previous year. And the first line about the adult programs, these community treatment programs, is that they have demonstrated a 6 to 7% decrease in homelessness, a 35% decrease in jail days, and a 15% decrease in hospital days. These are good stats. And these are very reasonable things to orient to, kind of in the hierarchy of needs, you could argue. But what's quite striking is that if you read through these, they're not focused on things like symptom reduction or quality of life, things that you might otherwise orient to in tracking mental health outcomes broadly. It's primarily about these things like homelessness, decreased jail days, decreased hospital days, which often also then get calculated in terms of cost. And some people on the ground think very cynically that that's primarily what it's about. So here's what Mr. Daniels, who operates a Board and Care, a kind of private psychiatric group home for the poor in Los Angeles, here's what he said. Basically, he thought his organization existed to help save the state money. You know the economics of this thing. One of the reasons why we exist, and I don't mean just us, is so that people are not burdening Medi-Cal and therefore the state and their budget by being in the hospital. Okay, so what's the clinical project in a place like actualization? So there, I got a very different picture of how they thought about what they were doing. Here's what Richard, the owner, said. A manic or psychotic person with resources and connections can do so much damage you wouldn't believe it, to their family business, to their community. So there's kind of emphasis on protecting these privileged families from the damage, the kind of relational damage, or even damage to reputation and business that a psychotic or manic person could do. And when I asked Richard about outcome data, they didn't have it, which is something I found also with some of these other elite places. They weren't really tracking things. And I asked him, are you being audited by the state or insurance companies? And he said this really interesting thing. Every few weeks, I've got to send a millionaire dad running a major company a bill for a few $1,000 bucks. He wants to know why is he paying it. I get audited every 2 weeks by everybody. So he wasn't actually formally getting audited. It was a question of, are these families who are paying expensive bills happy? That's kind of what they're oriented to. And you could read this in this very kind of cynical way of like protecting family reputations, pleasing the family. It's just this kind of social control project. I mean, sometimes. But also it gets paired with a very hopeful vision of the future. So here's what Deidre, the actualization clinical director, once said. We're not interested in how many hospitalizations have you had and what are your umpteen diagnoses. Do you want to make friends? Do you want to recreate? Do you want to go to school? Let's do it. Okay. So then we're going to turn to this idea of social prognosis. Like, what are the possible futures they envision for their clientele? How is that bound up with and then also influencing treatment? And so I'll talk about this by looking at two people who have arguably a similar kind of psychiatric profile, but a very different social profile. So Delilah and Gwen are both women in their 50s who are diagnosed with major depression with psychotic features. So at the DMH, Delilah was a poor African-American woman who was outreached. She was living in front of an Albertsons supermarket for several years. At the actualization clinic, Gwen is a wealthy white woman who's brought in by her family. So, what is the trajectory and imagined future for someone like Delilah? So it's primarily about getting her into housing and stabilizing her social situation. So they helped move her into an apartment, and then they conducted home visits. I went with them to check up on her, and the language was, we have to go see if we need to put her in, meaning like, has she crossed a hospitalization threshold? And so they're checking up on like, is she eating? Things like this. And the imagined future they have for her is that she could eventually get off what some social scientists call the kind of institutional circuit, right? Bouncing between street, jail, shelter, brief hospitalization. And so from their perspective, like Delilah was doing pretty good. When I talked to her later, when she was describing her life, she said, well, I sit at home and I watch TV or listen to some music. Everyone in my family works. I don't get to see no one during the weeks, months, years. So in some ways, she's telling me a story of loneliness. But what's also important here, I mean, from the clinic's perspective, is that she hasn't hit a hospitalization threshold, and she's staying in the unit. And then a case manager said she's ready for that next step. And the thing they were imagining for her future was that pretty soon she was going to age into senior housing. So she would no longer have to live in a building simply for DMH mental patients. She could be in a kind of general subsidized housing for seniors. And how are they thinking about Gwen's future at the actualization clinic? And Gwen had just come out of a psychoanalytic residential program, about 30 days, in LA. And so she goes through a variety of interventions, right? So this kind of psychoanalytic approach, med cocktail, electroconvulsive therapy. I met her in the actualization clinic's IOP, their intensive outpatient program, like 3 days a week of group therapy. And here's how psychologists on the team talked about Gwen. I had a similar patient who had become psychotic after being a supermom and a member of the community. Not consciously, but the psychotic issue was an exit strategy. Whether or not we would agree this is, the proper kind of dynamic interpretation, it's already a very different kind of story where people are trying to make sense of what's going on in her psyche to perhaps explain some of the symptoms she's experiencing. And they became really stuck on this idea of Gwen having lost her voice. They said she has no voice in her family system. And that became something they wanted to work on. So their imagined future was this kind of viable identity for her. And so it brought a couple of things together. Their theory was kind of that Gwen had given up her career for being a stay-at-home mom, and then when her kids left the nest, she kind of lost her sense of herself. And she began to use this language too. So she told me, I want to put myself back together. It's a big life change to have your kids grow up and leave the nest. And they became fixated on this idea again of helping Gwen get her voice back. It was kind of very liberal feminist framing about how she needed to assert herself, tell her family no, became a big thing, and they wanted her to return to work. And I should say work here is not actually about an income or paying the bills. Her husband's like a kind of Hollywood bigwig, so it was really more about role development. And so this is this kind of very different future they're imagining for Gwen. And in each case, both with Delilah and Gwen, they're sort of paradigmatic. This is kind of what they're aiming for in these different clinics. And each of them are kind of on their way. But what about when people aren't really matching up with these kinds of social prognoses in the clinic? So when do these things become detached? What happens? So at DMH, you have the case of people who seem to be sort of recovering in terms of symptoms, but there's not really that much more to be offered them in terms of building a social life or an identity. And some of them get stuck in these kind of benefit traps. The actualization clinic, on the other hand, will have the opposite problem, which is what I call an optimism trap. So here's an example of somebody with this kind of mismatched social prognosis at the DMH. Jeremiah was a Jamaican man in his 30s who was diagnosed with schizophrenia. I first met him on outreach. I was with the treatment team. We met him. He had a towel wrapped around his head. He was muttering and drawing things in the dirt. And they eventually got him into stable housing. He stabilized on an antipsychotic. He also had very minimal side effects. And a case manager said, wow, like that's what hope looks like. But when you talk to Jeremiah, he didn't really agree. And he didn't want to badmouth the treatment team because he was very grateful for what they did. But he's a case of what I would call symptom recovery without social recovery. Here's what he said. Housing, food, clothes, it should be more too, right? When you've gotten the person on the meds and they're doing fine, you want to get them to the point where they're working instead of just not having anything to do. I'm still young. And he worried that he wouldn't really be able to fulfill his potential to contribute to society. So part of this is the fact that the treatment team, they kind of have other fires to put out. He's kind of achieved what they're aiming for, so it to some degree stops there. He's also trapped by the structure of the US welfare state, which is for people with disabilities, you are kind of constrained here. So if he graduates from the program, he risks losing these DMH subsidies that help him stay in stable housing. If you work too much, you risk losing your other federal subsidies for things like either income assistance or even your health care. And at the actualization clinic, though, they have kind of the inverse here. They have what I would call this optimism trap. So as an example, Anthony was a white man who turned 50 when I knew him. I met him at the IOP, so in this intensive outpatient program, the 3 days a week group therapy. He was also going to individual therapy. He was diagnosed with schizophrenia. And he was doing all of this kind of intensive therapeutic work, and things didn't seem to be changing for him. He got very frustrated. And here's what Nate, the director of the IOP, said about Anthony. He said this to me, he wouldn't have said this stuff to Anthony. Well, his brother is married and has a couple of kids and runs a successful business, and Anthony wants all that for himself. But he's 50, and he's still struggling with his hallucinations. Treatment providers may have a different view of the likelihood of his ultimate plan succeeding, but you don't want to discourage them from their dreams in any way. Nobody knows the future. And at one point I was toying with the idea that, that very cynically, what the treatment program is doing is not telling Anthony that they don't believe in his dreams, but trying to keep him, in treatment as long as they can, because that's a way to extract a lot of money from his family. Again, they're paying out of pocket. At a certain point, they stop being covered by any insurance. They're just paying for it. But I got to know Nate, and I don't really think that. I think this is just what makes sense in a clinic like this, is you focus on this kind of optimistic future, even when it starts to not really align with what you think is real. And then there are ways in which these privileged families and their class ideas about what success means actually end up interrupting seemingly very good psychiatric rehabilitation outcomes. So as an example, Herbert was a man in his early 30s who was diagnosed with schizophrenia, and he achieved what they considered a good psych rehab outcome. He was starting to work at a P.F. Chang's chain restaurant, but his upper class family said, well, he can do much better, and so they got him to quit. And then finally, how do these kind of social prognoses impact ideals around patient autonomy? And so what I'm going to argue is that, at DMH, because recovery is essentially defined as keeping people housed and out of jail, it leads to a kind of generalized harm reduction, a set of practices that give people a great deal of autonomy, depending on how you define autonomy. Whereas in the actualization clinic, because respectability is so important in the idea of recovery, it can lead to a kind of paternalistic micromanaging and arguably less client choice and freedom for the privileged. So at DMH, they came to see people's so-called problem behaviors as kind of de facto choices, like what are you going to do about it? So here's what Laura said. A nurse said to her, why are we putting these people who are so sick into independent apartments off the street? And Laura said, at least they're safe. People like them are not going to do what we want, but what can we do? These are the behaviors that kept them in the streets. And what Mr. Daniels, the boarding care owner, he said, sometimes there were formal harm reduction logics, and then sometimes it was just a question of not having enough staff. So I was at this boarding care late at night, and I was with some clients, and then people were just openly getting high. But on the wall, you say a thing that says this is a sober facility. And I talked to Mr. Daniels about it, not ratting anyone out, just kind of asking about it in the next week or something. And he says, well, do we have rules that say you're not supposed to be drinking? Yeah. So I don't have a guard standing in front of each room 24 hours a day. It's not possible. So sometimes they end up with a kind of de facto choice harm reduction model simply because they don't have enough staff to surveil people, despite what they claim they would do. And I'll just give you an example of this. You have this generalized harm reduction logic that's primarily about just trying to avoid bad situations. And so they come to believe you can't really change people's behaviors, but what you can do is you can redirect them. In many cases, because they're oriented to housing, the people they feel accountable to is landlords. So as an example, Sandy was a white woman in her 40s who was diagnosed with schizophrenia. They outreached her on the streets of Skid Row and moved her into an apartment building that was not in downtown. And it was an apartment building that had a mix of people who had housing vouchers and the people paying market rate. And Sandy repetitively banged her head on the wall she shared with her neighbor, who as far as we could tell was paying market rate, and was very upset. And so he was trying to get her evicted. So I went with Beth, the social worker, and she came up with this plan, which was that she told Sandy, don't bang your head on the wall you share with your neighbor, bang your head on the wall that goes out to the street. It'll make less noise. And very creative. It's not like they have some in-depth therapeutic or behavioral program. They can't force her to take medication. They sort of see this as very creative. And then Beth also had this this thing that I've ended up talking about as finding the right ecological fit for people. And what she said to Sandy also was well, maybe we'll have to move you if this becomes a problem. She said, you can choose to live like this, but not in this building. We might need to find you a dirtier building. Which is in fact what they eventually did when the landlord truly started to threaten eviction. They moved her back to downtown LA. And I just want to stop here and highlight this. This is a little more, sort of sociology inside baseball. But this is sort of puzzling, given a lot of the research literature on social control and class. So a lot of research suggests that poor people who are quote unquote social deviants are going to either end up criminalized and incarcerated, or perhaps surveilled and disciplined, a sort of Foucauldian model, try to render them into market actors. Maybe you leave them to die in what people call zones of social abandonment. But actually none of these things are happening here. What actually is happening is it's not like a zone of social abandonment. Actually, they're putting her in a nice area. She's not being criminalized. There's an assumption, as I mentioned, of in many cases of drug use or bizarre behavior. And so this question arises of why are these poor patients given this type of quote unquote freedom within state subsidized housing? And the way I've come to talk about this is it's what I call tolerant containment. It's this kind of spatially specific acceptance of so-called problem behaviors, and it comes out of what sound like pretty good things often, like drug decriminalization, harm reduction logics, progressive public health logics, but often stripped of the kind of care and resources that might allow a kind of alternate way of generating social order and health. So what you end up with is this kind of what I would call civil liberties to social deviants, but without social rights to resources. And tolerant containment, once I started thinking of it that way, I started to see this kind of thing in a lot of other cases. And it's this kind of general strategy that cities have to stem costs and mitigate disruption when a more corrective approach to social control is either ineffective or it's just too expensive for them. And so we can also see this when you look at the contrast with what elite people are paying for. And here's what Dev, a case manager, had to say. And he had an interesting perspective because he did his social work internship at a Housing First type program, which he said he admired. He thought they did a really good job for the downtrodden, but he also said it didn't make sense for this kind of elite private care he was working in. He said, those programs don't care if you don't take meds, even if you do drugs to a certain extent. They're more kind of about keeping you out of prison, keeping you out of the revolving door of hospitalizations. It's ultimately their goal. It saves the county a lot of money. But what if you want more than that for your loved one? And from Dev's perspective, if you want more than that for your loved one, you don't kind of give them autonomy. You try to find ways to subtly control them. So here's an example. Because again, these are folks who have not met any necessarily a hospitalization threshold. They're not necessarily under conservatorships or guardianships. So you find these very subtle ways to manipulate their choices. So as an example, Roy was a white man in his 30s diagnosed with schizophrenia, and primarily would be considered negative symptoms. He wouldn't leave his room. He just wanted to read manga and watch TV. And a case manager said, what should I do with Roy? When I asked him what he wants to do today, he says nothing. And Deirdre, the clinical director, said, well, we don't want to infantilize our clients, but it's like with my kids. If I ask them what they want to do, they want to be on their phone. You want a bike ride or get something to eat? If they want something else, you say, sorry, that's not an option. And so they gave Roy options, and he chose from a narrow string of so-called healthy options. And what they landed on was taking him to restaurants where he could work on trying to deal with the social anxiety that would come in a busy space. It was very hard for him, but he later told me it was worth it, that it was better than any medication he'd ever taken. And what these places are going for is a kind of, there's subtle distinctions here, but it's a type of order and social control that's not punitive. So here's what the owner of a place I call Namaste Garden said. This is a beachside mental illness, chemical addiction, dual diagnosis, sober living home. And he said, some other programs allow the person to just take their meds, sleep in, and just kind of shuffle through life. It's not going to happen here. We're meditating every day, surfing every day, going to the gym every day. Those bipolar and schizoaffective clients can't handle any kind of stress or confrontation, but they flourish in a healthy rhythm. And so, well, first of all, I should say, this is an idealized representation. They don't actually surf every day, but it's he is describing a very different pattern of everyday life in these kinds of treatment homes, where it's yeah, you're meditating, you're going to the beach, they're doing yoga. And what he's saying is look, you don't want to just let people shuffle through life, that's not good, but you also can't, he's not saying punish them, right? You can't confront people diagnose a schizoaffective disorder in this way. What they need is this kind of healthy rhythm of discipline, from his perspective. And really, any shelter can be mean and threaten people, that they'll kick you out if you don't comply. But this kind of highly ordered time control, this is something that I think you need a lot of money to do because you need a lot of staff. And this could lead to a strange kind of domination that was unlike anything I'd ever seen in the public sector. So as an example, Kayvon was a Persian man in his 60s who was diagnosed with schizophrenia. He believed any new activities would lead to a catastrophic event in his brain. And Dev, the case manager we met a few slides before, essentially forced Kayvon to play soccer. And Kayvon said, "Dev, please no." And Dev said, "It would be a disservice if I allow this to continue because it impacts the quality of your life." And so afterwards, I think Dev could read on my face that I found the whole situation a little strange. And this is what he told me. "Well, with the private sector, I don't know if the right word is you can get away with more. But for instance, with Kayvon, we push through things. But in the public, I might not be able to do that. They could think that's not ethical." But for Dev, he was the one who was doing right by Kayvon by not letting his seeming delusions prevent an increase of quality of life. So in summary, coming back to this idea of social prognosis, so the psychiatric prognosis refers to the predicted course and duration of a mental illness. In this case, the social prognosis is about the types of lives that are envisioned, the types of identities they think people might have. And what we're seeing is within these different clinics, you have very different goals, different views of the possible future. And some key features of the social prognosis here is I'm arguing it's shaped by the clinic, by what resources are at hand in the wider context, but it in turn ends up shaping what kind of interventions feel practical or possible, or what feels like appropriate for this kind of person. And in some cases that may become quite disconnected from where the client is at or what they seemingly need. Just to put these things side by side, so in terms of the clinical project, you have this idea of kind of managing urban poverty, homelessness, and disorder versus addressing these dynamics within privileged family systems. You have a social prognosis of getting somebody housed off the institutional circuit, or you have the social prognosis of building them a kind of respectable identity. You have this mismatch though, because you have people at DMH who kind of stabilize and then get stuck. There's nothing for them to do, and they're stuck also by kind of the structure of the US welfare state. And at the actualization clinic, you have this mismatch of people who are kind of not really achieving, but they're still being pushed towards this kind of respectability in a way that can, as in the case of Anthony, lead to a lot of psychic pain. And then in terms of client choice, it leads to very different ideas around what it means to offer people choices. So at DMH, they've come to this kind of radical choice, generalized harm reduction model, whereas at the actualization clinic, there's this real emphasis on trying to induce proper choices. And so the implications for practice, I'm very curious for people who are practitioners, just like, if this resonates with you, do you think this social prognosis thing, does it make sense, and does it shape how people view patients and treat patients? I'm curious how you think clinicians should serve patients whose experiences are at odds with this kind of organizational level social prognosis. And then, there's this question of, if it is all embedded in social context, what can individual practitioners do? And so because of this last one, I want to shift a bit to the writing I've been doing on social policy, kind of some of the bigger things I try to tackle in this book. So I'll take us through three. So one is about kind of making sense of where we are, the kind of policy landscape. California specific, but it's going to, I think, be partially applicable here too, in New York. Then we talk about the importance, I think, of qualitative research and qualitative thinking in mental health policy debates. And then I'll talk a little bit about institutional design. So this is a piece I wrote for the Washington Post in 2021. I'm just trying to make sense of what was going on in California. The West Coast has become a kind of boogeyman for people like Brett Stevens of the New York Times, who were saying how can we trust Democrats? Look at their cities. And indeed, people were saying what is this? In LA, this photo was from, I was at the big Echo Park homeless encampment for a big sweep, but it had been around for over a year. What's going on in places like LA and San Francisco. And what I end up writing there is that this idea of what I call tolerant containment, this kind of civil liberties without social rights, had become a kind of de facto social policy approach throughout the state. So we ended up with things like court decisions saying that you had a right to be homeless, but no right to housing. That was Martin v. Boise, the Ninth Circuit, although that's been overridden since then. but this was kind of the landscape at the time. You ended up with things like partial drug decriminalization. You have a right to possess meth and heroin, but no rights to rehab or any services if you want them. Similarly, we have a kind of right to refuse psychiatric services, but no right to psychiatric care if you want it. It's kind of Frankenstein's monster, as I would say, of civil liberties and austerity, a lack of public goods. So that's trying to just sort of map out like what's going on, and so sort of seeing, as I would argue, that this tolerant containment approach actually stemming from the history of deinstitutionalization. Like we've repeated this logic over and over, which is kind of civil liberties victories, but without the public goods in place or the services in place, or community services in place that could, again, generate a kind of alternative social order and health. And turn to this thing about like qualitative thinking that I think is missing in a lot of mental health policy debates in general. And coming back to this idea of social prognosis and how do we define success, I've been interested, both in California and then in New York, we've seen this kind of interest in the resurrection, either bring back the asylum or the kind of expansion of inpatient care, block units. And so I was following a series of debates over Proposition 1, which was a $6 billion bond measure in California last year, where people kept debating like, well, how many quote unquote beds are we gonna get and at what cost and in what speed? And this is a piece I wrote for the LA Times where I said like, beds, it's basically meaningless, right? Like a bed can be a dungeon, a bed could actually, depending on how you do it, could be a place of healing. Work, all of these things, if you don't make these qualitative distinctions, like a work program and treatment can be slave labor, or it can actually be designed in a way that's potentially therapeutic. And we need to think seriously about quality of care, kind of think about what future are we envisioning for these patients, both within that treatment and then when they step down. Because we also know that poorly implemented coercion backfires tremendously. We see things like elevated suicide rates in some research, total treatment disengagement in the future. So if you're going to do this, you have to think about actually doing it right, whereas so much of the public debate just ends up being these kind of cost-benefit analyses that are extremely uninformed. Similarly, when it comes to the question of housing first is very much under attack by the Trump administration. There have been these debates about like, does it work? And there's a question of like, well, what do you mean by work? And so there were these debates around the statistics. You'd see things like good outcomes on housing retention, but kind of mixed outcomes in the meta-analyses on health outcomes. And what I've ended up writing about is like, yeah, if you see this on the ground, a lot of things are getting called housing first that have very little to do with like the original New York City Pathways to Housing first model was. You see a lot of things fly under this label, some of which are quite good and others are basically what I call tolerant containment. And then finally, taking this kind of perspective, I won't go too much into this, although I'd be happy to talk about it. It's just bringing this type of research and mindset more into the design of things like care courts, which are a novel coercive treatment mechanism in California, hospitals, and people are talking about bringing back the asylum. You have these very polarized yes-no debates, whereas people are, to my mind, not talking enough about design, how you do this well, or at the very least less bad. Because when I talk to activists who are abolitionists on this, it's like, these things are coming. So do you want to have your voice involved or not? And the framework I'm using is what I call institutional harm reduction. With Alex Bernard of NYU, we've been writing about how do you incorporate more, especially more service user input into design. I won't go into it just for the sake of time, but happy to talk more about any of those as well as the rest of the talk, of course. So thank you. I will close this out and sit there.